Fantastic. Thank you for joining me for this great case. We have a case that was presented, a 26-year-old female casted 4 months ago, hallux valgus, sesamoid displacement, perhaps sesamoid hypertrophy, perhaps the ATFL is an issue in the ankle, and we can take a look at the case here on Collective Minds Radiology. And when we look at the case that's presented, we can go through our usual ankle checklist, and then we can go through a 4-foot checklist to assess what's really going on here. And what I can tell you about this case is I love axial imaging. So I'm just going to dive right in, and you can follow along on your own and then go back to pick up some of the pieces. The things that I usually begin with, I dive right in and I'm going to look at my medial flexors, my lateral flexors, and my extensors. So rolling through my tendons, my PT, my flexor digitorum, and my flexor hallucis longus tendons, I can see some mild tenosynovitis. The posterior tibial tendon, about 2.5 times the size of the flexor dig, qualifies for tendinosis. Gets to my medial navicular, I can see here, tendinosis again, and then I can see my bands towards the cuneiform and metatarsal attachments, which I'm going to see much better when I look at that on a coronal image, and I can see those where the posterior tibial tendon inserts and then where those features go to insert on the base of the cuneiforms and the metatarsals as seen here on portions of the foot. Getting to the lateral flexors now, we can see that we have a low-lying muscle here, and that's an accessory peroneus quartus. We can have our brevis and longus here. Looking at our peroneus brevis, we can see it comes all the way down to the base of the fib, and there's quite a bit of irregularity going on at the base of the fib. There are features here where the abductor digiti minimi are attaching, but then we have quite a jumble of extra signal intensities here that is where the peroneus brevis wants to insert. So I want to identify that on a coronal image. That brings me to how far, when we look at this coronal image, we're looking at the peroneus brevis and longus. Following this brevis here, we can see the brevis all the way here. Now, this is the last slice, and we see tendinosis, but they didn't actually bring it all the way to the base of the fifth. And that's something that we want to educate our technologists about why they would be bringing the coronal images to the base of the fifth metatarsal so we can assess that. But luckily, this person also received a foot MRI. So though the resolution is not as good, we can still make our way down with the brevis. And we see this irregularity here and a little bit of edema in this location. And what I would want to do is to take a look on my axial T1 to understand, do I have any changes? See, I have some kind of changes along the bone. We can see a small osteophyte, and now this hypointense T1 change at the base of the fifth metatarsal could be construed as a non-displaced fracture or a stress fracture there. I'm going to try to see it on my proton density axial, but again, when we use proton density for bone marrow, it's not as good. So I'll be looking to use STIR or some type of equivalent to STIR, a Dixon, or a variety of newer techniques have occurred on either GE or Siemens magnets. But what I'm looking at on peroneus brevis is still not well resolved. So what I think about this is that I'm going to call a non-displaced fracture or base of fifth metatarsal, at least apophysitis. And if the patient has point tenderness in this location, I'm definitely going to want to at least get an x-ray. I might need to get a CAT scan, non-contrast of this location, just to understand the bony structures that I'm having difficulty working out on the MRI, what is going on exactly here. But I'm going to be calling peroneus brevis insertional tendinitis and non-displaced fracture at the base of the fifth metatarsal apophysis for this particular case. And I don't think it's brand new. Remember, this patient's been casted for 4 months, so we expect this to have healed already if that was the initial injury, and my student can help me with that. So that's my peroneus brevis. My peroneus longus, the common pathologies there are going to be type 2 tendinosis along the lateral calcaneal sidewall as it has to get towards the base of the first and attach. And what I have in this location is a mild degree of tenosynovitis and tendinosis in this location, and I'll be letting the clinician know that. Moving to my extensor tendons, my tibialis anterior, no problem there. I see my remaining extensor tendons, and I see this fluid collection. And this fluid collection actually isn't part of the extensor tendons. It's deep to the extensor retinaculum. So let's take a look at that on coronal image. And when we see on coronal image, what is happening is that there's an intraligamentous ganglion cyst coming from the sinus tarsi. And what it's doing is tracking along the roots to the extensor retinaculum. And why that's occurring is biomechanically important, because when I heel strike and then I move to toe off, the body needs to know where I am in space. And these retinacula help to guide my biomechanical function by tightening up my extensors as I heel strike and get ready to move on to my toe off phase of gait. This is a sprain of that particular biomechanical moment. Moving on, the Achilles. What I have here is some mild tendinosis, trace retrocalcaneal bursitis, plantar fascia. What I see here is relatively normal. I don't see fibromatosis. I don't see tear. I don't see significant thickening, but I do see a pressure point in the heel. This is not something easy to accomplish. So this tells me this patient is truly heel striking. And when I think about bisecting the ankle, this is a medialized heel strike for my podiatrist in the room. A medialized heel strike is something we can see on MRI. Let's get to the deltoid ligament. Move into the deltoid, the deep deltoid fibers here. I can see there's some traction, cystic change. This is a chronic sprain, subacute on chronic when I see synovitis. The tibial spring is seen very well here. This is our superficial deltoid. I love to look at my superficial deltoid axially. The anteriormost fibers are my tibio-navicular. The central fibers, tibio spring. Posterior band, tibio-calcaneal. The main band I'm always focused on, and I can see the best, is my tibio spring as it plunges into my supromedial band spring ligament. We can arbitrarily divide this ligament into an anterior, central, and posterior band, and that's where these superficial deltoids are attaching into that. So it's like a curtain that's coming into this floor. The floor is going to insert above the posterior tibial tendon on the medial navicular through the supromedial band. Then we have our medial and inferior plantar bands. And I use T1 weighted image to see those better. So that way I don't overcall them, because in the axial plane, they often look like they're sprained, but it's really just a matter of the signal intensity in the axial plane. Okay, so we've done our deltoid, we've done our lateral caudal ligament complex. The syndesmosis here is intact. I do not see interval widening. I can see my interosseous membrane and ligament. I can see my posterior syndesmosis, my anterior syndesmosis here. All good. And lastly, I'm going to look at the bones now. And when I look at the bones of the ankle, there are many configurations and variations. We've come to recognize several different types of coalitions besides osseous, cartilaginous, fibrous coalitions. And fibrous coalitions bring up a whole range of types of coalitions. And I think it's essential that you start with understanding the subtalar joint anatomy. In order to understand coalitions, it's essential to see what are the cartilaginous surfaces. In this case, we have a variation. The middle facet is continuous with the anterior facet, and it's rounded this way. In some patients, it's very straight, and there are different angles to them, and they're cut differently. But in this case, you notice there's a rounded appearance. So that's just one thing to notice, that this person has a continuous anterior to middle talar facet, a subtalar facets. Now let's take a look at the articulation between the anterior process of the calcaneus and navicula. And I like to look at it on T2 so I can understand that this is a very broad-based region that is really locking the cuboid, calcaneus, and navicular with the anterior subtalar joint. So I can see that I don't see any degenerative change. So for now, I'm just going to hold off on calling this coalition. I'm going to go through the rest of my checklist, and I'm going to look at my posterior subtalar joint. I'm going to come to the medial side. I'm noticing has an extra articulation on the medial side here, and even some mild degenerative change. So I'm going to be calling this an extra articular anteromedial talocalcaneal coalition that I see here. And I am going to hold off from calling this a coalition in this location. I could be wrong. This might be a cartilaginous coalition, but it looks thick enough that there'd be two layers. The resolution of this particular exam does not allow me to be more specific than that in my experience. So after that, I'm, of course, always on the search for bone marrow edema and osteochondral defects. I can see that there's some chondral thinning at this anterolateral talar dome, and we could probably see that better on the proton density if we go side to side, that the anterior cartilage is slightly thinner than the posterior cartilage. But this is mild tibiotalar degenerative change. I see some dorsal talonavicular enthesopathy. I see the base of fifth metatarsal, not much going on the proton density, because I think it's underestimating the degree of injury there. And that's what we have for the bones. So that's our ankle report. So in the ankle, the positive findings for this particular case are going to be, one thing I didn't mention, let me just go back to that. In the sinus tarsi, we have partial obliteration of the fat, and we have this ganglion cyst towards the roots of the extensor retinaculum. I'm looking here at my lateral talar process and my angle of Jussian, and I'm seeing cystic traction changes at the angle of Jussian. Let's take a look at that coronally and see these traction changes along the talocalcaneal ligaments. When you have features like this, patients may present with a lateral hindfoot impingement. And when I see changes like this, what I think about is that the medial portion really wants to get down to the ground. So they want to get that hindfoot valgus occurring in this patient, which can be associated with pes planus. So, altogether, when I think about the biomechanical alignment of the foot and the different features that are occurring, what I think are the positive findings moving through the systems are hypertrophic posterior tibial tendinosis, mild medial flexor tenosynovitis, subacute on chronic deltoid and tibiospring ligament sprains. I have insertional peroneus brevis tendinitis, split tear, and healing stress fracture at the base of fifth metatarsal apophysis. I want to collaborate that with an x-ray or a CAT scan to see the bony structures better, to understand truly if it's healed. The lateral collateral ligament complex, I have a subacute on chronic sprain. This is more on the order of chronic, but the edema that I see here in the calcaneofibular region, I think it's ongoing. So I call that subacute on chronic sprain occurring at the lateral collateral ligament complex. I have ganglia at the roots of the extensor retinaculum, and that may be a finding that indicates altered biomechanics. And then lastly, I have a extraarticular anteromedial talocalcano coalition, mild dorsal talonavicular degenerative change. And now we're ready to move on to the foot portion of the examination.